So today's talk is on critical appraisal using hierarchies of evidence from evidence-based practice. And we can see here as we kind of get into the critical appraisal element, we're going to not just have hierarchies but worksheets. There'll be something called systematic reviews and clinical practice guidelines which help us understand which articles to focus on. But right now, one of the key things, the principles that evidence-based practice is based on is the understanding the hierarchy of evidence. So we're going to go ahead and, pardon me, and look at that. So the first column or theme related to evidence-based practice is therapy or prevention. And when we look at this ranking, we have the rankings here on the left from 5 is the low level and 1 is the high level. We can first see that an A is typically designated by something called an SR. So we have 1A is an SR, 2A is an SR, 3A is an SR. SR stands for systematic review. And we'll get to systematic reviews at the end of the class. So for now, what I want you to do is ignore the A's and focus on the other levels or rankings. And we look at the 1B's, we can see that there's something called an RCT. There's some other detail here, but for now, try just to focus on the research design. So we see RCT for the 2B's. We also see a cohort study or an RCT that's not very good. It says low quality. RCT for a 2C, we have this thing called an outcome study. And then it says or ecological study. So just a rephrasing what that study's about. And then for a 3B, we have something called a case control study. And then for a 4, we have something called a case series. So we can see that in order to understand this hierarchy or this column of the hierarchy, we'll need to know the difference between an RCT for 1 grade, a cohort study, and an outcome study for 2 ranks of a 2, a case control for a 3, and a case series for a 4. Here's the entire hierarchy of evidence, and I'll put that you can see that we're kind of breaking down here. There's a therapy column, a prognosis column, and a diagnosis column. We'll just kind of keep going. This is the diagnosis column, which we'll be doing soon. And again, the same thing is true for the A's. We're going to ignore because they're basically systematic reviews. But then the 1B's and 2B's, what we see here now is we see cohort study appears in 1, and cohort study appears again in 2. So the study design in this column for diagnosis doesn't distinguish between a 1 and a 2. Something called the type of cohort study. See, we have one as a validating cohort study, and the other is an exploratory cohort study. So it's more this idea of validating versus exploratory, which separates a 1 from a 2, and this diagnosis column. And then basically a 3B is a non-consecutive study. So basically this has to do with how the samples collected, not the design. And then finally we find another design, case control. So essentially, the diagnosis column only has 2 types of study designs, a cohort study and a case control study. The last theme or column that we're going to concern ourselves with is prognosis. So again, we have the ranks here, and then we start to look at the details listed here. And we're going to, again, note that the SR, the systematic reviews, are the 1, 2A's, and then there's no 3, so there's no 3 in this case. And so we'll ignore those. And then again, look for names of study designs and the listings here. So we see for individual inception cohort study. So here we have a cohort study again, so this is a theme. So usually a cohort study for therapy was a 1, for diagnosis and prognosis, a cohort study is a 2. Or is also 1. My mistake there. And then for a 2B, it's a retrospective cohort study. So basically, it's all focused on cohort studies. And then the only others, I guess the outcomes research comes back again. So this is the same as for therapy. They have outcomes research or ecological research as a 2C. And then finally, for 4, there's a case series. So here we have 3 different types of research design. So the only column that's heavy on research design is therapy. But by covering therapy, we kind of hit on the concepts of all the different research designs we need to know, with the exception of the retrospective cohort study. Okay, so what we're going to do now is start a discussion of what the different individual research designs are and how you conceptually think about them. And then we'll get into later how to identify them when you read an abstract or you have a paper or something like that. So we'll basically, you'll need to come back to this slide later, but there's basically three ways to know, three questions to ask to determine the design of a study. It's like, how are the subjects assigned to groups, random or not? Okay, and then how many groups are there? Okay, and then what is happening in time? Is it prospective or retrospective? And all of these should, if you can answer these three questions, most likely you'll be able to identify the design. So keep this in mind as we start to look at the different designs, and then you'll have to come back to that slide and think about how those questions relate to the different designs. It's a good study exercise for you. Okay, so for a randomized controlled trial, essentially there's a start point where the patients enter the trial. They're randomized to a treatment arm or a control arm, and then we measure, after they've been randomized, we measure their baseline values, and then we compare them at the end of the day to their post-test values, so after the treatment has been administered. So in this case, the treatment will be the independent variable, and then the dependent variable will be the outcome that's used to determine if the treatment was effective or not. Now, one of the things we talked about, or it's important to understand, is why the randomization is important. And the randomization is important is because it controls for known, and here's the key, unknown confounding factors, so that they're both equally distributed in the treatment group and the control group. Here's an example of a randomized controlled trial where they were looking at trying to improve ankle range of motion in people with diabetes mellitus and with tight Achilles tendons. So they basically randomized people into a group that received surgery, a tendo Achilles lengthening, or a total contact cast. And then they tested their range of motion before and after the two treatments, and then they determined which one had greater increase in range of motion, and that was the one that was the better treatment. And so if we look here, so the independent variable is the type of treatment, either contact cast or tendo Achilles lengthening, and then the outcome variable or the dependent variable was the range of motion. So in this case, the surgery was more effective in improving range of motion than the total contact casting. The next type of study design is something called a cohort study. It's prospective, so we notice that there's a pre-test and a post-test that's planned ahead of time. The eligible patients come into the study, but they don't get randomized to the treatment or exposure or the control. Rather, it's some other non-randomized approach. And then essentially it's exactly like our RCT, except for this lack of randomization. So you have a pre-test and a post-test. You have the exposure and control of the two arms or more. And then you have your dependent or outcome variable, which determines which treatment's better. Okay, so the key thing, though, is that a lot of times it's not really possible to randomize, or it's at least difficult. So a good example would be if a surgery may help somebody or a conservative treatment may help somebody, it's really the patient's choice whether they want to try the surgery or not, and randomizing them to the surgery group may just not be plausible or ethical. And so in that case, it's common to have groups that have get surgery and other ones that get conservative care because of patient choice rather than randomizing them. So that's a good example of why that might occur. And here's another example. Sorry for that little faux pas there, but essentially this is a prospective study. This is about ACL prevention, so the idea of prevention is very similar to therapy. you're delivering an intervention to try to stop something that hasn't occurred yet rather than treating a disease. So basically, they had high school teams. They had a PEP program that potentially would limit ACL tears. So at the beginning of the study, nobody had an ACL tear. And so they offered this to different schools in the Los Angeles region. The ones who adopted the program, so it's not, again, it's not random, notice, became the intervention group. The ones that decided not to adopt the program became the control group. And what they did is then tracked the injury rates in players that adopted the PEP program and then the ones that didn't adopt the PEP program. And you can see here's the dependent variable. They have tears per player. So there were 2 tears per 1,000 players in the PEP program group, and there were 32 tears in 1,900 players in the control group. So there were many, many more tears per player in the control group. So the treatment was successful. But that's an example of a cohort study because there's no randomization at baseline. Okay, so the next treatment group, or the study that we're going to evaluate, this is a level 2C. And so in this case, we have eligible patients, and we go to treatment, and then we go to the outcome. So notice right away that we don't now have multiple treatment arms, and so that's a big step down from the other studies we've been looking at. The other studies allowed us to make analytic assessments or comparisons between 2 treatment arms, where this one does not. All right, and so essentially, this is an outcome study. So the idea is that you test people before they start their treatment. You let them receive their treatment, so you do nothing. Let the normal processes that occur when delivering treatment occur, and then you measure them at their near or at their completion of treatment. And this is called an outcome study because it's just purely descriptive, documenting how the effective the treatments are and changing different attributes on in terms of in body structure and function, activities limitations, or participation that are important to those individuals. And so we can see here is that that's a pretty good, I mean, that's a kind of a pretty simple design. And let's look at an example. So in this particular example, they documented the outcomes that are associated with patients with a severe brain injury and acquired brain injury with ankle contractures. And essentially, they documented their kind of range of motion before and then after, and then after they got treatment, they retrospectively went back and documented the different treatments that they had received, and then grouped the people into different groups. And so the treatments were prolonged weight-bearing stretches, motor re-education, cerebroplaster casting, with botulinum toxin injections. And then they noted that they described, and 23 patients responded to stretching and motor re-education. 10 of 17 patients received a combination of serocasting and injection, and 7 were deemed too severe for further treatment. So essentially, what we can see here is that we have these kind of groups that get formed, but it's after the fact, and the key is that there's no assumption of equivalence across the different groups of patients that receive different treatments. They received those different treatments precisely because they were different, which means that this is a purely descriptive study, and it would be incorrect to compare these 23 patients to these 10 to these 7. They're basically just describing what the different outcomes were for different people and what different treatments were used. And so one of the discussions that you may think about, so if it's just purely descriptive and it lacks the ability to make comparisons or be analytical, why is it ranked at 2C? Well, it's ranked at 2C because it can validate the practical application of a experimental treatment that might have been affirmed with a randomized controlled trial. So for example, if a randomized controlled trial suggests a very positive outcome, 80% of the people compared to the control group are doing much better. An ecological study like this that just tracks what happens to people might get downgraded some, usually because the success of a randomized control trial is partly tied into the sophistication of the people performing the test, and it's usually new, and those things kind of favor a good outcome. And so in the everyday practice, the actual outcomes may downgrade a little bit because lack of expertise or difficulty applying those techniques in a practical clinic setting. And so an outcome study is seen as a way of validating outcomes from either higher level studies or just describing the current state of care. Okay, so let's move on to the next observational study. Now, this one, in fact, you can make some comparisons, but let's see how that works. This is called a case control study, and essentially what you're doing is flipping the group assignment. So before, and we have the same diagram, before we would have people come into the study and we would assign them to the intervention arm or the control arm. Now we're calling the exposed or not exposed arms. And prospectively. But what we're going to do instead now is we're going to assign them to the groups based on their outcomes. So rather than do it based on their exposures or whether they got the intervention or not, we're going to put them into groups based on whether they have the bad or the good outcomes. So do they have the disease or not have the disease? And so that's what we see here. So, and then what we're going to do is see up here, we're going to retrospectively look back in time and track how many of them were exposed to some harmful thing or some beneficial thing and how many were not in each group. Okay, and if the proportions are different, then we would say that exposure item or that beneficial item can be attributed to the patient's status. Okay, so here's an example. It's commonly used, the case control studies are commonly used in imaging to associate different imaging findings with disease. And so we're going to use disc herniations to look at this. So basically, this is a case control example, the one that we saw before, where they basically looked at people, they grouped people with low back pain, without low back pain, so with the disease and without the disease. And then they wanted to see if a herniated disc was associated with low back pain. So they took the number of people with a herniated disc and looked at the proportion of those without a herniated disc, and if there's a higher proportion of people with herniated disc in the low back pain group compared to the no low back pain group, then that would suggest that, yes, the herniated disc is associated with low back pain. If the proportion of herniated disc to no herniated disc is the same in the low back pain and the no low back pain group, then the answer would be no, that the herniated disc is not associated with low back pain. So this is an example of a case control study where you're looking at these proportions in people who've been divided based on some outcome, in this case, low back pain. Okay, so the final study design we're going to look at for this talk is the case series. And so notice immediately that it looks almost exactly like the diagram, looks exactly like an outcome study. So essentially it's relatively simple. You have a pre-test and a post-test, okay, and the post-test determines the outcome. Now, the key difference is, and you can underline this if you want, is that treatments are manipulated by the researchers and clinicians. So we're talking about so in this study, what's going to happen is that rather than just letting the patients enter treatment and get whatever the therapists choose, what you're trying to do is isolate some new regimen for therapy or surgery or what have you, and determine whether it has a significant effect. So you can see this as one arm of an RCT without the control. And a good example would be if somebody had like an aggressive rehab program that they were trying to introduce for chronic stroke, or a new aggressive program for tendinopathy that would have better results than a previous study, you would use this to introduce your novel treatment of an aggressive approach, or something like constraint-induced therapy. Before they did randomized controlled trials for constraint-induced therapy, they had to have preliminary trials that just showed that there was some benefit to doing the constraint-induced of the therapy with the uninvolved arm of people after a CVA. And so based on those preliminary trials or these case series studies, then they could plan future research. So a good example is also, it's used often by orthopedists to introduce treatments. So here is an article by Dr. Flemister. He had patients with posterior tibial tendon dysfunction. Then this really aggressive surgery that entails lengthening the lateral column of the foot. So they actually put a bone wedge between the cuboid and the calcaneus, which expands the lateral side of the foot, which in turn raises the medial lungeal arch. And then they combine that with a tendon transfer to remove the posterior tib or augment the posterior tib tendon. And those two, that's kind of a pretty aggressive surgery. And so basically what they were doing is just describing their results after performing this surgery on a selected group of patients. So that would be an example of a case series study. Highly defined treatment. Everybody gets the same treatment. And it's one of the common purposes is to introduce a new treatment or a novel approach to care or to a patient group. Okay. So one thing that's useful, if you'd like, I would recommend that you go to the Center for Evidence-Based Medicine website and read this one-page summary of studies. And basically what you can see here is they identify 3 questions for you to ask to determine what the study design is. The first question is the study analytic or is it descriptive? And what's nice about this is that a descriptive study, you can see here they're using the PICO format, really only has a patient and outcomes. And so, it's kind of a survey kind of thing, but they could also have case series studies here, and also that aren't listed. Case series studies would be appropriate, and an outcome study would be appropriate, because both of those are purely descriptive. Now, analytic studies can kind of make some kind of comparison. And so in that case, it's going to be appropriate to have a PICO, because in a comparison, you'll have an I and a C and an O. And so basically there's experimental and observational analytic studies. And so if it is analytic, then you have to decide if it's experimental or not. And basically, experimental means it's going to have randomization. So if it has randomization, it's going to be likely an RCT. There's something called a crossover design, which we will cover here. And then if it's an observational study, it's either going to be a cohort or a case control. We won't include a cross-sectional in our discussions. Okay. So there's also something called a case report, which is a description of an individual patient, and usually these are considered opinion or a level 5. So I hope this helps you reinforce the concepts of study design and apply them as we go through the class. We'll have many more exercises related to this. Please try not to get lost like these ducks. Okay, thank you.